Hello, everyone. My name is Paul Miller, and I'm a physician who is the medical director of the Colorado Center for Bone Research, and I'm also my academic appointment as Distinguished Clinical Professor of Medicine at the University of Colorado Health Sciences Center. That's my official title. Let me tell you who I really am. I'm a nephrologist by formal training, and I currently do a fair amount of renal bone work in terms of renal disease and the kidneys, but most of my work is as a referral practice in metabolic bone disease and clinical trials in metabolic bone disease. The bone diseases that I manage are a lot of complicated postmenopausal osteoporosis and other forms of osteoporosis, including other secondary conditions such as steroid osteoporosis, post-transplant osteoporosis, Mayo osteoporosis, and then a fair amount of work in Paget's disease, osteogenesis imperfecta. And I've had a lot of experience in bone densitometry development and application. I've been honored to be one of the founders of the International Society for Clinical Densitometry, the ISCD, which is dedicated to teaching physicians and technologists how to do bone density correctly and interpreting them correctly and good quality control. I've also been heavily involved in biochemical markers of bone turnover development and particularly their application in clinical practice. And that's the focus of this presentation today. And I hope I can make this both interesting for you and exciting for you so that you begin to learn how to apply bone turnover markers for certain specific reasons that I think are beginning to get more utilization in the general practice community. So let me go to my next slide here. And it almost looks like a summary slide, and it is in some ways, but it's not in other ways, because these are the points that I am going to talk a little bit about throughout this session, and to provide some level of evidence and also a lot of clinical personal experience on how I use markers. I use markers in untreated patients who have high baseline values for a number of reasons. High baseline values predict a higher risk for fracture beyond bone density alone, and I'll explain that why in a minute. But I think one of the things that I don't want to forget is that high markers, and we'll talk about what markers are and what markers are used, but high markers also think outside the box, because not everybody that's postmenopausal has high markers has the high markers from being estrogen deficient. They could have high markers due to a number of other conditions that can cause high markers, such as myeloma or severe hyperparathyroidism or other items. Secondly, I use markers in untreated patients to tip the scale to decide when to treat, because in the risk models that we have, the fracture risk models, such as the fracture risk assessment modeling created by the genius of Professor John Canis in Sheffield and underwritten by the World Health Organization, the validated 10-year data to use risk factors to predict the 10-year risk of all major fractures or hip fractures, did not include markers because markers weren't available when FRAX was initiated. It's not a flaw of FRAX, it's simply a timing of how biology and the information has changed over time. People that have high markers will approximately double their fracture risk above and beyond what's calculated by FRAX alone. And I use that value of a high marker in those cases where I'm trying to decide in borderline cases of whether or not they have a high risk. In treated patients, number 3, and particularly patients that are on anti-resorptive agents, such as bisphosphonates or even full-dose estrogens or Denosumab, the markers in the clinical trial data, particularly the C-telopeptide, the CTX, is the bone resorption marker that comes from collagen, the collagen cross-link. Markers that are above 250 picogram per milliliter should raise some concern about whether or not they're taking the drug, the compliance is bad, whether they're absorbing it, if it's an oral bisphosphonate, or there's something else mitigating a bone biological effect. Now, as I'll go through the data here, you'll see that the normal premenopausal range for the CTX is approximately, from the best data we have, about 150 to 650 picogram per milliliter. And certainly there'll be lots of people on oral bisphosphonates that won't be below 250. That simply comes from some of the Fosamax data, the alendronate data, the Fosamax long-term extension, where the majority of the patients were below 250. And sometimes a single value, if it's within a normal range, may not be as good as if it's a very high value or a very low value, because you don't know where they started from. But that's something to consider if it's above that level. In treated patients, a change, a drop from baseline in a marker or an increase with an anabolic marker, a marker that stimulates bone formation, has some meaning. The drop in a CTX from baseline, probably beyond 30% from the baseline value, or an increase in the anabolic markers, and this could be either propeptide type 1 collagen or P1NP or serum osteocalcin, which fit on the lines with very similar changes in response to the only anabolic agent we have currently available, and that's teriparatide. An increase should be 10% above the baseline value. Certainly is indicating that they're having a bone biological effect. And then we'll get into this very hot topic of the issue of bisphosphonate drug holidays and how markers might help us in deciding whether the bisphosphonate is still being recycled and working, or whether the bisphosphonate pool has been depleted. But let's start over with going back to some basic biology, and that is, what is turnover? You and I, men and women alike, we replace our entire skeleton about every 10 years by a process called bone turnover or bone remodeling. They're fairly synonymous terms. Throughout your entire skeleton, you have about 5 million of these. Each one is called a BMU, or bone remodeling unit. Within any one unit, there's a fixed program, and it takes about 120 days on average to complete this cycle. But it's the bone remodeling cycle where bone resorption occurs and then bone formation occurs. And this is going on at different sequences throughout the skeleton all the time. And the purpose of remodeling or turnover is twofold. One is to maintain the blood calcium, normal, because the skeleton is the major reservoir for calcium, and you can't maintain a blood calcium by taking in calcium. So there's this flux of calcium in and out of the skeleton, which is regulated by a whole series of both external and internal processes. The other purpose of remodeling is to repair the little microcracks, the stress damage that occurs when we're doing activities like running or walking or in Colorado skiing or whatever, to repair bone. So this is the cycle within any given level of a bone remodeling unit, that they're laying there having a holiday, taking a rest, and something comes along and activates them. Externally, it's predominantly parathyroid hormone. Internally, within the bone microenvironment, one of the dominant regulators is the rank ligand rank system, and that activation results in bone resorption by the osteoclast, and it takes about 30 days on average to carve out an area of old bone. And then right behind that comes the activated osteoblasts, the cells in bone that make bone, to form bone, put down bone matrix and then bone calcium, and replace that amount of bone that's been carved out when bone is in good balance. And so this process of bone remodeling takes about 120 days on average to complete. From the cells in bone, from both the osteoblasts and from the bone matrix, the collagen, are released proteins into the blood that are termed under a generalized heading of bone turnover markers that we can measure in the blood and give us some sense not a perfect sense, but some sense of what's happening with the remodeling rate, with the bone turnover rate in patients. Now, it's not clear what is the optimal bone turnover rate. We have some data that if the bone turnover is too high, it can impair the strength of bone and lead to fractures. Or at the other spectrum on the left-hand side, if the bone turnover is too low. So for example, in conditions where there's very high bone turnover, such as severe hyperparathyroidism or space travel, for example, or immobilization, it can lead to impairment in strength of bone quality and bone strength. On the other hand, there are conditions where we know that the bone turnover is too low, and those could be like renal adynamic bone disease. It might be the process, one of the processes that leads to impairment in bone strength in diabetes, in people on glucocorticoids. But very low bone turnover also is associated with poor bone quality, poor bone strength, and increased fractures. So how do we measure these biochemically? Well, here is a list of the available bone turnover markers, or often abbreviated capital BTM. On the left-hand side are the bone resorption markers, and on the right-hand side are bone formation markers. On the left-hand side, the preferred, and these are preferred by both the International Osteoporosis Foundation and the International Federation for Clinical Research, who have met to come to some consensus on this, and in the United States by the American Association of Clinical Chemistry and the National Bone Health Alliance, a part of the National Osteoporosis Foundation, who have come to an agreement on preferred markers. Under resorption markers, the preferred marker is the serum, or in Europe, it's the plasma, C-telopeptide, or CTX. This is a collagen cross-link from bone collagen. It is specific for bone collagen, not from collagen of your knee, your nose. There are other bone resorption markers that are available, but not used commercially yet. The TRAP5B, or tartrate-resistant acid phosphatase, which is actually a cellular marker of osteoclast number rather than true bone resorption. On the right-hand side, the bone formation markers, and the ones that are preferred are the propeptide type 1 collagen, or P1NP, that comes from the osteoblast, but also, because it's much more widely reimbursable, is the serum osteocalcin, particularly the mid-osteocalcin molecule. And I'll show you some data of how the P1NP and the osteocalcin track each other in almost a linear fashion in their results. The bone-specific alkaline phosphatase, or BSAP, is also a very important marker because it goes up in a lot of diseases that may not be related to osteoporosis, although it can go up in osteoporosis as well when you have high bone turnover. But for example, in other bone diseases such as Paget's disease, it's the preferred marker. It also goes up in bone with metastatic cancer. It also goes up in bone after a large bone fracture. It also goes up in bone with severe vitamin D deficiency or osteomalacia. And so it's a very important marker to use for a number of other different metabolic bone diseases. So this is a slide that I gave this year at our annual ISCD meeting in Orlando. Again, the clinical use of markers to explain in part the higher fracture risk that may be seen at the same bone mineral density, to monitor pharmacological response to treatment that is valuable and complementary to bone density, because markers change faster in response to treatments. They'll change within a month or 2 months or 3 months, and can provide you an earlier feedback of what's happening, whereas bone density will take a year or two to change. to predict the rate of bone loss. There's data to suggest that higher markers will predict higher rates of bone loss. We'll talk about holidays. And for those of us that do renal bone disease work, and since I do most of the bone biopsies for the Rocky Mountain region, and not everybody has access to bone biopsies or bone biopsy reading, there's recent data indicating and suggesting that specifically measuring parathyroid hormone, which we won't talk about today, or the bone-specific alkaline phosphatase may help discriminate among some of the different forms of renal bone disease or renal osteodystrophy, and in some cases may obviate the need for a bone biopsy. Some potential advantages of markers is because they represent an integrated dynamic assessment of skeletal metabolism. One of their disadvantages, and we'll show you in the next slide, is that they can't tell you what bone they're coming from, or whether they're coming from a single bone or many bones. We assume that in systemic bone diseases like osteoporosis, they're an integrated measurement of what's happening systemically. The rapid and large changes with therapy or off therapy are probably one of their great advantages. And the assays are widely available both commercially from different labs and by different machines. And I think that some of the work that we're doing right now is to try to standardize some of these, but they're very accurate and widely available. Some potential disadvantages, these are slides from my good friend and colleague at UCSF, Dr. Doug Bauer. Again, they cannot distinguish whether it's coming from cortical versus trabecular bone. There are some markers that require that they are collected fasting before 10 o'clock in the morning, and that's particularly true of the bone resorption marker, the C-telopeptide. There is between laboratory variability, standardization needs to be improved, harmonization of the assay needs to be improved, and the project that we here are working under the leadership of the NBHA is to try to establish the consistent normal reference database with men and women on both of the available immunoassay machines, the Roche diagnostic machine and the immunodiagnostic machine. It's important to point out and to always bear in mind that bone turnover markers cannot be used to diagnose osteoporosis. They can be used to assess rates of bone turnover, fracture risk, and changes with or off therapy. But the diagnosis of osteoporosis, as you know, is made on the basis of either a low trauma fracture in the absence of even bone density, or a WHO criteria T-score by bone density of -2.5 or lower. Either one of those are valid diagnostic criteria. I think it's also important for me to point aside that the T-score can be perfectly normal, and you can make the diagnosis of osteoporosis in people who have had certain types of low trauma fractures. And that's an important point to make. The rapid change. This is a slide from the UK, from Richard Estell's group, that shows on the left-hand side the change in bone density, and on the right-hand side the change in the marker with treatment. So you can see the right-hand side with treatment. This was with bisphosphonates. The drop in marker occurs beyond what's called the LSC, or the least significant change, within 3 months, whereas it took 2 years to see the rise in bone density with this anti-resorptive agent. And so again, this is how they can be complementary, because you can get an earlier feedback at a quicker, shorter period of time with the marker with the therapy. This is another slide from Uri Lieberman from Israel from the Lidernate data. The left-hand slide shows the percent change in the urinary NTX, which was the marker widely used in earlier days, and the marker dropping significantly by week 4 after starting a Lidernate, whereas it took at least 18 months in the groups of people to see the increase in bone density. So again, an example of how markers can be used and they change more rapidly. This is a slide, again, from the UCSF group, from Dennis Black who's done a major amount of work in this area. This is the change in the CTX in the red, the bone resorption marker, and in the green, the bone formation marker with alidronate. Now, you're going to ask, well, why are you using a bone formation marker to monitor a change with an anti-resorptive agent when you have the bone resorption marker? The principle of this slide is to make you realize that for most of the drugs that we have in most bone biology, the osteoblasts and the osteoclast cells are coupled. That is, whatever you do to one cell line, there'll be a directional change in the other cell line. So when you decrease osteoblast and the osteoclast activity with alidronate, the CTX will drop rapidly. And then ultimately the osteoblast activity will go down, and that's demonstrated here by the drop in the osteoblast marker, the P1NP. So actually you can use a P1NP as a bone resorption marker. It takes a little longer to get the resorption marker, the formation marker down with anti-resorptive agents, but this is the principle of the biology of the coupling of bone cell lines. In the same vein, this slide shows the rise in the osteoblast marker, the P1NP, when using an anabolic agent that stimulates the osteoblast, but also shows the rise in a slower rate in the bone resorption marker, the NTX with teriparatide. So here you get a stimulation of the osteoblasts, and so in the green, the P1NP goes up faster and higher, but then in a delayed manner, the NTX will go up as well. And this is the principle of coupling, and this is a nice demonstration from the paper in the Archives of Internal Medicine and this head-to-head trial by my good friend and colleague, Mike McClung. Another slide by David Dempster, our good Scottish friend and histomorphometrist at Columbia University up at the West Haverstraw Hospital in Helen Hayes, New York. This shows, again, that comparing teriparatide on the left, an anabolic agent, with zoledronic acid on the right, an anti-resorptive agent, and in the green, the P1NP, in the pink, the CTX, and again with the anabolic agent, the faster and earlier rise with an anabolic marker, P1NP, but then later on a rise in the CTX. On the right-hand side with the anti-resorptive agent, the faster drop in the resorption marker, the CTX or C-telopeptide in the red, followed by the drop in the bone formation marker, the P1NP. Underpinning again the known biology of a coupling of bone cell lines. Bone markers can be used as a predictor of increased fracture risk. Population studies, elevated markers increase fracture risk in untreated patients, at least in groups of people, and it's a risk factor not captured in FRAX. This comes from probably the pivotal study of that. This is a population study from France, from Pat Garnero, published in the JBMR, showing this is the EPIDOS French population study. For each 2 standard deviations of CTX above the T-score, the odds ratio for fracture risk doubled. So here, going from left to right, the increased fracture risk based on low bone density of the hip by itself. In the middle, on the high CTX by itself. The CTX is in the white. Another bone resorption marker was DPD, or deoxypyridinoline, which is not used much any longer. But then you combine the two, the low bone density and the high marker, it gives you a better prediction than either one alone. And this was probably the pivotal study that pointed out this utilization, at least in groups of patients, of how high bone turnover can be used to predict the increased risk of fracture at the same bone density. This is a summary of a number of other population studies. The one that I just went through initially is the EPIDOS study. There's studies from Rotterdam, the Oefele study, the Jerdam study, showing that for a marker that's elevated, and these are in the upper quartile of the normal reference range, for example, that it increased the odds ratio of different types of fracture, hips fracture, non-spine fractures, spine fractures, above that assessed by bone density alone. This is a study on the formation markers. This one here was the bone alkaline phosphatase, or the serum osteocalcin. Again, a high marker predicting an increased risk of fracture at equivalent BMDs, bone mineral density. This is a long longitudinal study that was published by Vasaka from Malmö, Sweden in the JBMR in 2010, that a high CTX in the highest tertile 9 years later predicted an increased hazard ratio of all clinical fractures, and that was adjusted even for the baseline bone mineral density. So it looked like a high marker over a long period of time predicted an increased risk of fracture. And there's a lot of theories behind this. It could be because higher bone turnover, you've got more resorption cavities, they make it deeper. The areas that David Dempster has described well on electron micrographs of what are called stress risers. There are more of them. They become weaker, and the bone may fracture at the equivalent BMD. Again, in groups of patients, reduction with anti-resorptive agents predict a decreased risk of fracture. This is a meta-analysis from Mark Hochberg at the University of Maryland in the rheumatology division, showing the drop in the bone resorption marker over time in a number of studies with anti-resorptive agents. Most of these were bisphosphonate studies, different bisphosphonate studies with alendronate, recidronate. The point of the slide is that there seemed to be it's not a true linear relationship, but some linear relationship between the magnitude of drop in the NTX in this particular study, bone resorption marker, and the magnitude of reduction in fracture risk. This is another slide that came from the alendronate data. This was from Richard Estelle's publication, the JBMR in 2003, looking at urinary CTX with recidronate and showing that there was a relationship between the magnitude of reduction in the CTX and the magnitude of fracture reduction in incident vertebral fractures. This came from the alendronate data. The last one was from the recidronate data. This came from the fracture intervention trials, so again from Doug Bauer, using, again, the bone formation marker as a resorption marker because, again, the coupling between bone cell lines. And this slide shows the relationship between the drop in the bone alkaline phosphatase and the reduction over 4 years in incident vertebral fractures. This is a more recent slide looking from Jacques' group in JBMR 2012, and this shows in the zoledronic acid studies the relationship between, this is a log scale, between, and the placebo is in the dotted line, the placebo is in the solid line, and zoledronic acid is in the dotted line. The drop in the P1 and P, again using the P1 and P as a resorption marker, to the magnitude of fracture risk reduction in the zoledronic acid trial to show that that's compared to placebo, the greater reduction in bone resorption led to a greater reduction in fracture incident rates. In the Freedom trial, the data with CTX and P1 and P, there wasn't enough data captured on the markers to show the relationship between marker changes with Denosumab to the change in fracture risk. We certainly have a very linear relationship. Denosumab data between the increase in total hip BMD and the exceptional fracture risk reduction that was seen at the hip with Denosumab, but no bone turnover marker data. What about anabolic data? This is a slide looking at the changes, comparing these two anabolic markers, if you want to look at it that way, the P1P and the bone alkaline phosphatase. And this just shows that with 20 micrograms a day of sub-Q of teriparatide, the P1P shows greater increases. And even though it's not shown on this slide, serum osteocalcin tracks the P1P changes closely as well, much better than the bone alkaline phosphatase as an anabolic marker. This slide here shows the change in the P1CP, which is another portion of the peptide that comes out of the osteoblast. On the right-hand side, in a similar result, is the P1NP, and this shows the increase in P1NP from baseline to 3 months later, highly related to the increase in the spine BMD at month 18. So here, a 3-month increase in P1NP, highly correlated with the improvement in bone density later on down the road. Now this is an interesting slide because this is a histomorphometry slide looking at different parameters of bone from bone biopsies, looking at bone volume, looking at the width of the trabecular area, and this is looking at bone alkaline phosphatase. The point of this slide is to show that, again, an increase in a formation marker was highly correlated with improvements in certain microstructural changes of bone by bone biopsy. This is from Harold Dobnik's paper published in the JCM in 2005. This is a paper that we recently published. John Craigie, a clinical scientist with Lilly, was the first author on this paper. This is the pooled data from the various teriparatide clinical trials, looking at the change in the placebo group to the change in the P1NP from baseline to 1 month after starting teriparatide. If you pull this article that was published in Osteoporosis International just this past year, it will show you that an increase in P1NP from baseline of more than 10 microgram per liter was highly correlated with increases in bone density, was highly correlated with increases in bone microstructure on paired bone biopsies, so that the cutoff point for what might be a pharmacological response to teriparatide is an increase in P1NP of 10 microgram per liter. There wasn't enough fracture data in these pooled trials to say what the increase in P1NP from baseline would translate into decreases in fracture incidence, but certainly there was enough data to look at it with a change in bone density or bone microstructural improvement on paired bone biopsies. This is a nice paper from Sarah Glover, who, working with Richard Estelle's lab in the UK, published in Bone in 2009, looking at different markers: the bone alkaline phosphatase, the osteocalcin, the P1NP, the P1NCP, with teriparatide, and then, of course, on the right-hand side, the bone resorption markers. And what this slide shows fundamentally is that the increase in the P1NP and the osteocalcin are very similar as osteoblast activity marker responses to teriparatide, better than the bone alkaline phosphatase or P1CP. And that's the point of that slide by Sarah. Now, this is a little harder to read, and I apologize, but this also comes from Richard Estelle's group, looking at the changes in serum osteocalcin. Now, this is another osteoblast activity marker in the glucocorticoid data from the top panel, the premenopausal women, in the middle panel, the postmenopausal women, and the bottom panel, the men, and showing that even at month 1, again, as compared to alidronate, the osteocalcin goes up. You would expect to go down with the alidronate, and these changes are seen early, even in month 1. And in this particular slide, you can see this even in the patients on steroids with osteocalcin as an osteoblast marker. This looks, again, at this whole biology. This is from John's slide that show, again, the increase in the bone formation marker with teriparatide, even at month 1 after starting. No change at month 1 in the bone resorption marker, but because of the coupling between bone cell lines, that when you increase bone formation or osteoblast activity, you increase osteoclast activity, and then ultimately you'll see the rise in the NTX. Certainly the preferred marker for monitoring teriparatide will be P1P or osteocalcin. But this just shows the biology, again, of these coupling of cell lines. Now, what about drug holidays? Drug holidays become a hot topic, particularly in the bisphosphonate field. And this was an FDA hearing September 9, 2011, that was ultimately followed by 2 editorials in the New England Journal of Medicine, one from the FDA itself, from Whitaker and colleagues, and then another accompanying editorial by Dennis Black and Doug Bauer and colleagues, because the FDA was interested in limitation of use for 2 reasons. One was the fact that bisphosphonate pharmacology is very unusual. The only drug in clinical medicine that's not metabolized, they get retained in bone and they get recycled, come off bone surfaces, go back to another bone remodeling site and continue to work. And they have this recycling phenomena that can last sometime for a long time and have a persistence of effect after discontinuation. Another concern, another reason for considering a holiday was the lack of efficacy data beyond 5 years, which is really something that may not be achievable anyway, because you can't continue placebo groups and you're always beyond 3 to 5 years for ethical reasons, and you're always comparing incident rates beyond that with the old placebo groups. The third reason was the appearance of these atypical subtrochanteric femur fractures, these rare fractures that are dramatic though, which are not seen hardly in anybody before 5 years of use. So what do we do, and how do we tell patients, and how do we counsel patients when we stop their therapy? And this is a challenge because there's not a lot of data. And so a lot of this will be opinion and some practical clinical guidance on what we think about. Well, what about markers? Well, this comes from the FLEX trial, the Fosamax long-term extension, looking at the serum CTX. On the left-hand side of the horizontal line is the FIT trial, the fracture intervention trial, the pivotal trials that led to alidronate's approval. This is the data on the left-hand side is between the placebo and the treated groups followed for 5 years. The FLEX data, or the so-called Fosamax long-term extension, it was the women that agreed to go on to 5 more years, and it was the treated group that agreed, that were re-randomized into either continuing treatment that's shown in the yellow or coming off. So fundamentally, the ones that came off had been on for 5 years and now were taken off. The serum CTX begins the rise. You can see that it actually became significantly different than those that stayed on at year 3, not at year 1 and year 2. So this is a hint, a suggestion that maybe the biological effects of bisphosphonates is waning after people have been on for 5 years by year 3. The real question is what happens to the fractures, because even though bone turnover may go up, it doesn't necessarily translate into impairment in bone strength. And we do have some fracture data in the FLEX trial. In the people that were taken off, there were no differences if you go from right to left from hip fractures between those that stayed on and those that came off, in non-vertebral fractures, or in morphometric X-ray defined vertebral fractures. There was, however, a 55% greater increase in clinical painful vertebral fractures in those that came off than those in the yellow that stayed on for 10 years. This data would suggest that there could be a relationship between the rise in the marker and the increase in the fracture risk. This is not proven. This is not validated. The statistical power of this was not done to look at these relationships in that manner. This is an association between the rise in the marker and the increased risk of fracture. Similarly, in the Horizon trials, the zoledronic acid trials, the patients that got in the core study in the black 3 years of zoledronic acid, then a group were either given 3 more doses, so they're called the Z6, the one in the orange. They got 6 doses of annual 5 milligram zoledronic acid, and a group that had been on for 3 years were taken off the so-called Z3P3. This is the change in the P1NP. The P1NP, again as a resorption marker, because of the fact that when you increase bone, when bone resorption begins to go up, you'll see a rise in the P1NP as well. You'll see that the P1NP went up, and it was increased by the second, maybe 18 months of stopping, and stayed at that level. And those differences were significant from the ones that stayed on. Here is the change in the fractures. In the extension study, there was only an increase in the morphometric vertebral fractures by about 30 or 40% as compared to those that stayed on. Again, data suggesting that there may be an association between the rise in the marker and the and changes in bone strength. It's not powered for this conclusion, but there is this relationship. This has come from a number of papers that we've published over the last number of years. Most patients don't stay on therapy. As you know, the compliance data, particularly with oral bisphosphonates, is poor. But to the extent that we try to keep people on, and keep people on for at least 3 to 5 years, you know, and now we have this direction of strong suggestion from the community that we ought to give people a holiday, particularly if they're lower risk, and maybe not give people a holiday if they're higher risk, or switch them to another drug. And in the United States, we have a problem with our legal issues with regard to what happens if a patient fractures because you kept them on, or if they fracture if you took them off. So these are important considerations. We don't know how long holidays are going to last, even though we have some of this data, because the pharmacology of bisphosphonates differ, and they may come off bone differently. And you never know from one patient to the next what their total skeletal load is of bisphosphonates, which may be dependent upon their compliance, or how much they absorbed, or how much of a remodeling space they had when they started taking the bisphosphonates. So in that regard, we have to do something, even though we don't have a lot of data by any means, to monitor people, to provide feedback to them, that whether you think this is still working or not working, and what to do. And so at the current time in the clinical community, you'll see a lot of development of guidelines suggesting that if you do stop bisphosphonates in lower risk patients, that we should monitor bone mineral density periodically and bone turnover markers. They're the only clinical tools that we have to monitor. It's important to point out that changes in bone density or bone turnover markers, in order to be significant, should be beyond the so-called LSC, or the least significant change of that marker, and that depends on the precision error of the lab, as well as the bone densitometry facility. What docs should do in these holidays: discuss why you're taking patients off. You should explain the differences in pharmacology, because we may not want to stop people necessarily in drugs that don't have the unique pharmacology of bisphosphonates. You stop statins, the LDL goes up. You stop high blood pressure medications, the blood pressure goes up. The bisphosphonate pharmacology allows this consideration. Explain that if their risk is low, that it should stay low because of this recycling. If they're high risk, and this comes from some of the directions provided by both the FDA in Whitaker's editorial and Dennis Black in his editorial, if they have high risk, that would be defined as people who have had prior fractures, or people who had femoral neck T-scores of minus 2.5 or lower, or older people who have a higher risk of falling. You should either stop them and put them on a different pharmacological agent, or if you're going to stop them, you have to watch them carefully. You should advise of symptoms that could precede an atypical fracture, even if you stop the bisphosphonate, because the risk goes down, but it doesn't completely go away. And we monitor height, we monitor bone density, we monitor bone turnover. It's all we have in our current clinical black bag. What about Denosumab? These are the last couple of slides, and we'll have a Q&A. Denosumab is metabolized. It's a monoclonal antibody to rank ligand. It's a wonderful medicine. It's got great data to reduce fracture risk at all fracture sites, given 60 milligrams sub-Q every 6 months. This is the paper that I was privileged to be the first author on in the phase 2 data. When you stop it, and you see the CTX here on the left-hand side, in the purple, you see the CTX not only going back to baseline, but it overshoots baseline within a few months. The effect goes away. The effect goes away rapidly. But we don't know what happens to fractures because there's no fracture data yet. But this is a drug that we probably have to continue at least for a long time in order to maintain the biological effect. That's an opinion. So what is the relationship between the rise in bone turnover marker and the subsequent risk for fracture? With discontinuation of Denosumab, we have no data. But I want to put in perspective the fact that the bone turnover being high as a reflection of an increased fracture risk in untreated people might be entirely different than changes in bone turnover markers in treated people, because there's a lot more to bone strength than bone density or bone turnover. So biochemical markers of bone turnover have complementary roles to bone mineral density in the management of postmenopausal osteoporosis, can be used for fracture risk prediction and monitoring response to pharmacological therapy for osteoporosis, show changes with therapy sooner than changes in bone mineral density, provide earlier feedback, and both resorption as well as formation markers are available and have specific value in specific clinical scenarios. And with that, I think I will finish, and thank you very much for your attention, for being here. I hope this was beneficial to you, and I'm very happy to take any questions that you may have. Don't be shy. I want to make sure that wasn't somebody calling. Okay, so here is a question. What is the relationship between bone turnover markers and fracture non-unions? That's a great question. I I don't know the answer to that. You would you I don't know if there's any data on that. If it is, I'm not aware of it. I would My opinion would be that if it's very high bone turnover, it could impair fracture healing. Although I don't know that. I would also think that very low bone turnover, and like for example, in adynamic bone disease, might impair fracture healing. I would bet you that there's some data out there, but I don't know that answer. Another question is, what are your thoughts on the use of strontium citrate for osteoporosis? Well, strontium ranelate, that particular salt of strontium, is approved in Europe under the brand name Protolos for the treatment of postmenopausal osteoporosis. And it's got some impressive, particularly hip fracture data in a very elderly population. There's a certain dose of strontium that's required to get this osteoblast effect, if it's truly an osteoblast effect. It may not be the case. And the problem is that the over-the-counter preparations that we have here are available, since strontium ranelate is not available in the United States, and they never did any clinical trials in the United States to get it an FDA approval, and I don't think it's available in Canada, is far lower than the proven dose in the clinical trial data. So if it has a biological effect, it's not been studied at these lower doses, and I look at it at the current time as probably being more homeopathic than truly with evidence-based data. Here's another question. This is a great one. They're all great questions. Thank you. What is your recommendation for monitoring a patient with glucocorticoid-induced osteoporosis on a drug holiday? Well, it could be a bigger problem because glucocorticoids suppress bone remodeling, particularly when they're chronic. And so you expect to see low markers. And certainly on bone biopsies, we see low bone turnover on dynamic parameters of histomorphometry. But they should come up, and they do come up. And the effect of glucocorticoids on inhibiting remodeling, inhibiting osteoblast activity, for example, should wane if they're completely stopped. And this may be a problem because they're often tapered down. And that should wane within a few months. And so I don't think there's a lot of data on holidays, but I think that monitoring CTX, P1 and P osteocalcin could be available, although the changes may be slower, but it may take them being completely off glucocorticoids rather than simply 2.5 milligrams of prednisone a day, for example. I would use them. I would look at them. I think the changes over time, that give you a trend over time, are much more valuable than a single measurement, that's for sure. And I think that I would use them and watch them in that regard. The problem, and that's the people that are completely off. The problem is that people that are even on 2.5 milligrams of prednisone a day, and this comes from the General Practice Research Database, the Von Style database, that even 2.5 milligrams a day, if it's given over a long period of time, will cause fractures as compared to no steroids. So I guess the question would be more probable in terms of changes that you would expect in management in people completely off. That would be my opinion on that. We still have 39 people on the line, so you got to have a question. This comes the fun part for me. Here's a question. Recommended clinical approach in postmenopausal women with osteoporosis with no previous fracture. Low bone density, and I'm assuming that the osteoporosis is being defined by the WHO criteria of minus 2.5 or lower. Low bone density predicts an increased risk of fracture, but it's heavily age dependent. So for every decade over the age of 50, the fracture risk doubles at any skeletal site at the same bone density. And that's because older bone has changes in bone quality that we can't measure yet in clinical practice. We may be getting a handle on this with the use of trabecular bone score, but that remains to be widely utilized. So the 50-year-old at minus 2.5 has a much lower fracture risk than the 80-year-old at minus 2.5. And that's probably one of the most important considerations is age. This is where I think the WHO FRAX helps us. The fracture risk assessment modeling. It was, again, the 10-year project underwritten by the WHO. There's an app for it now on your iPhone or iPad. And you can put in the 9 validated risk factors that were there and found to be validated over a 10-year period to predict the 10-year risk of either a major fracture or by itself hip fracture in untreated people. FRAX helps to some degree because it adds these other risk factors. It adds age. It adds whether you're on prednisone. It adds family history. It adds a prior fracture, although the question you have is without a prior fracture. Now, the question comes down to what is the FRAX score that would trip your finger to treat? Well, the recommendations out from the study, and remember this is a health economic study, is a major fracture risk of 20% or higher, or a hip fracture risk of 3% or higher. Now, I use that to some degree, but I modify it clinically. If I have a Parkinson's patient in front of me who's going to fall more, I may not use that threshold. It may be even a lower threshold. On the other hand, if I have somebody who is a Pilates instructor and can probably be on the Olympics on the balance beam, they're going to fall less, I might not use that threshold. Because one of the flaws of FRAX, say that 10 times real quick, one of the flaws of FRAX and is the fact that we didn't capture fall data, and most fractures, except for vertebral fractures, occur after falls. So I modify this in clinical practice. So if a person who's 19% and 2.9% has a CTX that's 1,500 with the upper limit normal 650, they have high bone turnover. I might start them earlier. That was the reason I put that in that slide about it might tip my scale. So I think that, and of course, you know, the NOF, National Osteoporosis Foundation, and other suggest treating people at minus 2.5 that are postmenopausal. I modify that according to age. I think that the 50-year-old who's out here in our state, where there's a lot of active people who have better muscle tone, will probably fall less or healthier. I may wait a while. If they're have high markers, I may not. I hope that answers some of your thoughts on that. Thank you for the question. It's a good question. Do you know if there are any updates to the use of bone markers in renal osteodystrophy? Yes, I do. In fact, and this is not to push my own horn, but in last month's American Journal of Kidney Disease, I wrote an invited review article on the bone diseases in CKD and how to discriminate them from osteoporosis. So it's the American Journal of Kidney Disease. I know it was online in January. I think it's out in hard copy, and I summarized some of that data in there. The best data comes from a group in London that looked at about 1,200 bone biopsy data collected over a period of time and correlated the degree of bone turnover with the tissue non-specific alkaline phosphatase and PTH. Those that had PTHs below 100 picogram per milliliter and a alkaline phosphatase in the lower quartile had a very high probability of having adynamic bone disease. If they had a PTH below 150 and an alkaline phosphatase in the lower quartile, the sensitivity for adynamic bone disease, I think, was about 85%. If they have a high bone alkaline phosphatase, they probably don't have adynamic bone disease. They might have hyperparathyroid bone disease. They may have osteomalacia. They could have Paget's. But it was the very low values that had a higher positive predictive value for adynamic bone disease, which is probably the bone disease that we want to exclude a lot of in people who you might be thinking about using anti-resorptive agents for fractures, because even though there's no data, it doesn't make sense to me, at least at this particular point in the science, to reduce bone remodeling when you have very little to no bone remodeling to begin with. But I think if you look at that, the original work was done by Garrett, but I review all that in the American Journal of Kidney Disease Review as well. That might be a little easier to get all. The Garrett's paper was, I'm blocking right now. I think the Clinical Journal of the American Society of Nephrology, I think it was the CJASN. That's a great question, and it's an important question. Well, I hear from Don that there's no more questions available. If you're still listening to me, I appreciate your attention, and I hope this was useful. Again, thank you very, very much.